Good afternoon. It is Saturday afternoon at 4 o'clock. It must be time for the senior moment. This is Connie Clark with Home Helpers, and I have two very special guests with me this afternoon in the studio. The first one is Donna Wilder, and she is with River City Hospice,
Yes.
and she has brought someone with her. And Donna, first, what is your function at River City?
I am the administrator and part owner of River City Hospice.
Okay, and you brought Nathan with
And
you?
I brought Nathan Ziegler. Nathan is our bereavement coordinator and one of our chaplain.
Very good. Welcome, both of you.
Thank you.
Thank you.
During the senior moment, we talk a lot about what kind of services you provide to the community, and it's more of an education. So explain to us, Donna, what does hospice do? I mean, everybody's always heard of it and always thought, okay, well, my loved one, they've said, may not make it for the next 24, 48 hours. Now it's time to bring in hospice, but that's not the case. So what does hospice do?
Well, what hospice is we are end-of-life care. It does take a physician's visit, or a referral to be able to be eligible for hospice. It is a Medicare benefit that is also available. A 6 months, in the doctor's opinion, 6 months or less end-of-life diagnosis. Now, as long as the patient meets the diagnosis or the time frame, we have patients that are on hospice up to a year, 2 years. It doesn't mean that you're going to, be on hospice and pass away in 2 days. We do have some instances that we have them on for a very short time, but we like to have them on longer than that because it takes time to build that relationship, not only with the patient but with the family, because hospice is about the family as well.
So when someone calls in hospice, tell me what happens.
Well, and we have that where people will stop by and they want hospice for their loved one. So what we do is we direct them right back to their physician to say you need to go and speak to your physician that you would like to have hospice come in, and they will look at that and say, you are eligible, or no, you're not. So that's the first thing. Sometimes they would prefer us to go talk with the doctor. So then what we do is we have them sign a medical release of information, and then we go to that physician and find out if they would be willing to write the order for hospice.
So the doctor writes the order, then tell me what happens.
Well, then from there it comes back to our intake coordinator at the office, and then we look at what the diagnosis is that the physician is writing for, and many people think that hospice is just for cancer patients, but there are over 10 non-cancerous hospice diagnoses. So it's not just cancer that makes you eligible for hospice.
Okay, so you've gone through, you've looked at the records to see exactly what's going on. Do you then go out and visit the family? Who does that?
Yes, well, sometimes, again, some people react of, hospice, I can't do hospice. My dad, I had no idea he was that ill. So we'll go out and do what we call a courtesy visit when the family has asked us to. And so it's more of an informational meeting. Some families come to us, they already know that, yes, they do need hospice. They do need that extra care for their loved one. Our social worker and our our RN goes out and does the admit. And then that RN writes the care plan, comes back, lets us know, CNA, how many times a week. Are they accepting spiritual, or are they declining spiritual? Because there's spiritual, social, volunteer, of course the bereavement, and the clinical. There's several disciplines to hospice care. It's not just the nurse that's there.
Okay, so she writes the plan of care, and it involves all of the different pieces.
It absolutely does.
So then what happens next?
Well,
kind of give me a general scenario.
Sure. Well, what we're going to focus on right away is the patient first. Making sure that patient is comfortable, that the needs are met, maybe bringing in a special bed for them, wheelchair, walker.
So you can arrange for equipment.
Oh, absolutely. Yes. Our RN, assesses what that patient is going to need. So from the medications to the DME. What hospice benefit, there is a daily rate that is given to the hospice And with that rate, it was to cover any staffing, any DME, which is durable medical equipment, and any meds that is pertaining to that hospice diagnosis. So,
Okay, so a nurse might come out to visit once a week, twice a week, whatever is deemed necessary
is
for the
correct.
person. And then you said there was a spiritual component.
Yes. Nathan, why don't you go ahead and share a little bit about that part?
Absolutely, yeah. That's part of the great thing of the hospice care is we do treat more than just physical
The
problems.
person as a whole.
The person as a whole, and as we know, we have obviously the physical ailment that they're suffering from. There's what I call the business end of the treatment, which is a social work, and then my specialty, which is chaplaincy, the spiritual part of a person. And so, and not even the patient is part of the equation, obviously, but even the family that's involved. The disease process affects everyone, not just the patient. And so when we're coming out of the admit process, I come out and I just introduce myself. I don't come in with any kind of an agenda of my own. I just try to open up that conversation of how do you deal with this period of life? What's your coping mechanism? Are there things in place already that I can make sure you stay connected with? Most people do have a local church that they're already in relationship with. Unfortunately, a lot of times what happens is as the disease progresses and that person is unable to make it to, say, Sunday service, they do become a little bit disconnected even from a church that they've attended before. So that's part of what I try to do, is to keep them connected primarily to their support system. And in the event that they don't have a support system already, then I become that for them. I am the person that they can just talk to. They can call at any time, and I'll come out and visit with them. I've performed funeral services for families that didn't have anyone in place up to that point. So, and then part of that group of what we call the interdisciplinary group, which is the clinical side, the nurses, the social work, and the chaplaincy, we all work really closely together so that if I see something that maybe the nurse didn't see, the more frequent the visits, the more set of eyes that we have on the patient and the family, the better care that we can provide to the patient and the entire family as a unit.
So you would work not only with the person who has the condition, but also to help the family deal with what's going on and find out what their coping mechanisms are.
Absolutely. And it's interesting, every family has a different dynamic, and so that's part of the first few weeks of being on hospice service that I enjoy the most, is just finding out what my role is within the system that they already have in their family. Their communication may be different than I am used to. Maybe the relationships are a little bit strained for different reasons. And so it's really a learning process for me, and that's part of what I enjoy the most about it, is just getting to know people, how they deal with this difficult time of life. And then it's a privilege for me to be invited into that spot of you're dealing with the end of life of your loved one. Everyone comes to grips with their own mortality typically at that point. And so it's a real sensitive time that I get a window of opportunity to speak hope and peace and joy, that this is a natural process. This is how God's intended it for us. It doesn't have to be so scary, and then just kind of walk through them with that and hopefully give them some tools to better cope with it.
Yeah, we see that same thing in families that start dealing with issues when someone is declining or when someone is having health issues. The family dynamics that might have been hidden for years, something that might have happened in the past, all of a sudden explode on the scene again.
Absolutely.
And you've got to deal with all of those issues in addition to the person you're trying to care for. And that can be very difficult.
It can be difficult, and I think that's the hurdle that we overcome as we walk through with families. And it's a scary time. It can be very uncomfortable, but it also can be, and from firsthand experience, I've witnessed it to be a very healing time as well. That a family can finally come in and say, there's many issues. Every family has issues, but let's make those kind of a side note and focus on the life of dad or mom or whoever the patient.
Of what's
may be
happening
before.
here.
Yeah, and so it's a time to where people really see kind of the bottom line of what life is, and a lot of the peripheral issues kind of fade away into, we really do love each other. We really can overlook some of the disagreements that we've had in the past. And then it makes that family stronger as they go through that, and then they can grieve together as a family, and it can be a real healing time as well.
I can see this beneficial. I've dealt with families who did not have hospice in and dealing with issues, and all of those things are still there.
Yeah.
There wasn't anything to make them reconcile with each other and to say, this is not important anymore.
Right. Yeah, it really brings a really healthy perspective. And then part of what I do as bereavement coordinator is then after the patient passes is we follow the family for at least a year after that to make sure that the things that we have set in motion before the patient passes continue on, so that healing process continues. The family hopefully becomes stronger as a unit. So it's not the service does not end at the passing of a patient.
Is there grieving support groups available here locally that people can go to?
Mm-hmm. We have a grief share class that we've set up at Real Life Ministries in Post Falls that meets every week. It is a volunteer basis, and that's the interesting thing about grief is that it kind of comes and goes. It can overtake you at moments where you just did not expect it. And so we do have those that come when they need it, and then find that it's helpful enough that they really engage and they can really walk through that grief process in a healthy way.
I agree with you there. I lost my dad in 2000 and my mom in 2006, and things still happen that choke me up, and that's been a long time.
Right.
So it doesn't go away. You're absolutely correct. You had mentioned that social work is part of this whole package. What does the social worker do as part of this?
With the social work, what they come in pretty much right off and see about kind of the dynamics of the family, and then look to see from do they have things in place? Does dad have a will or mom have a will? Is there durable power of attorney? If they get to a point where they can no longer make decisions, who is going to be that? So social work deals from a lot of the legal aspects that's needed. Also the planning that they would have for when the passing of the funeral home they want to use. There's just a lot of probably more of the legal business in
The paperwork kind of stuff?
Paperwork in the beginning, and then during that, then the social work, they as the chaplain, they see the dynamics of the family, of some that want to be engaged with their parents in this time, or brother, sister, and then some that they stay back because they just
it's hard.
Can't deal with it. Yeah, and that's one reason why we really like to be in there before they're actively dying, because actively dying, which we do have those patients, but we're focused totally on the patient. We don't even have time to build any bridges with the family. I think the average, we read somewhere that the average stay for a hospice patient is 39 days. Even though there's a 6 months or less end of life diagnosis.
That's interesting that you say the average is 39 days, because we've talked about people that have been on 6 months, a year, 2 years. So if you've got people that have been on that period of time, for the average to be 39, there must be a lot that are only on there for a very, very short period of time.
And it's for different reasons. It could be because the family, maybe the doctor has spoke to the family about hospice, but no, they're not ready to give up. Is what some people.
Well,
see
and
that.
if you bring in hospice, then you have to admit something's going to happen.
Right. But then those families that if they see, because we've had where patients are on hospice and then they're no longer eligible. They have gotten better because of the care of the relationships and things, and they're discharged because they no longer meet criteria.
I remember when my father was dying, they brought in hospice, and my mother just knew that hospice killed him. My father had Alzheimer's, and his health was failing. You could see him dying, and she just knew he was going to get better, and that if we hadn't brought in hospice, he'd have made it. So I'm sure there's a lot of people that have that thought, that if I admit that my loved one is going to be dying soon, then it's going to happen.
Yeah.
And if I don't admit it, it won't happen.
Right, and that's where spiritual and social, we deal with what we call false hope, of when there is a a true end-of-life diagnosis and there is steady decline. And that's where spiritual and social really help the family come to terms with that. But it's, again, it goes back to the dynamics of the family and then the patient too.
Mhm.
Because we've had patients that are just such a delight right to the end. I mean, it's about dignity. It's
Mhm.
about comfort and just the quality of life. And so, it's like Nathan said, it's a privilege to get to be into their home, to be invited, whether they're in a facility, skilled nursing or assisted living, or in their home. It's a privilege for us to be able to come in at such a vulnerable time in their life.
Very interesting. Well, we need to take a break,
Okay.
but I want to continue this because
Okay.
I love this discussion. I love learning things, and you guys are great. We will be right back on the Senior Moment. And I don't touch this because last time I did, I missed it.
So are you in here weekly?
Mhm.
Oh, okay.
I started out, I used to be on KVNI
Okay.
once a week, and it was like a 10-minute segment. And I was on there for, 2.5 years. And they changed format to the ESPN.
Oh.
And then they changed the morning show because the morning show used to go on till 9 o'clock, which made it nice because you could catch people driving into work, or just getting to work listening to their radio. Well, then they cut it off at like 8 o'clock, and they wanted me in there between 6:30 and 7. I thought, this isn't going to work. Nobody's out on the road listening, And so I did that for a few weeks, and then they started messing with my days of the week. Kept changing me. I thought, we're not going to do this. So I stopped them, and I had stopped the radio for maybe 3 or 4 months. And the gentleman that normally did the Senior Moment contacted me, or I contacted him, and I came in and I did a program with him, and we kind of hit it off, and he was going to go out of the country for a few weeks and asked if I would fill in for him.
Oh, okay.
So I did. And then when he came back, we talked, and he said, well, how about we do this? How about we alternate weeks? Starting the first of the year, I'll do 1 week and you do the next week. I said, okay, that's fine. We can do that. And now during the summer, he wants to take a break. So now I'm on every week during the summer until he comes back. So it's kind of worked out good,
Well, that's great.
and it gives, I think an hour gives a better opportunity to get into stuff.
Yeah, it really does. Well, I appreciate you giving us this opportunity.
Mhm.
to
Oh,
share.
yeah,
So,
absolutely.
yeah.
Absolutely, because I'm always trying to, I can't sit here and talk for an hour.
Yes.
To bring people in to
Yeah.
talk to me.
Right,
you
sure.
know, So, and every time I bring someone in, I learn something else,
Yeah.
so it's my learning also. So we're going to continue on then, and I want to continue talking about the social worker and the legal documents.
Okay.
And the kinds of things, because a lot of people don't think about that kind of stuff.
Okay.
And the importance of bringing you in early when the person still is cognitive enough to do those things if they're not in place. Okay. And we're back with the Senior Moment. Again, this is Connie Clark with Home Helpers, and I have Donna and Nathan with River City Hospice, and we're talking about hospice and all the different pieces and what they do and all that mystery stuff that hospice is. And we were talking about the social worker, and they do the legal documents.
Yeah, they really look at, when they come into the home, they really look at what does the family have and not have? Do they have a DNR, a do not resuscitate, or is the patient choosing to be full code? We need to know that. Do they have a power of attorney? And the power of attorneys, there's the medical power of attorneys, there's the financial power of attorneys. For a patient that, for instance, is dementia, they cannot sign for themselves the hospice benefits, so they have to have a power of attorney to sign for that. So again, the social worker looks at all that to see in place. If not, then we have the forms, and the forms are filled out and documented, and it goes in the patient's chart.
And they would also help if funeral arrangements and that sort of thing aren't
Yes.
done?
Yes. And depending on where the family is with all of this, if the funeral arrangements are talked about the first visit, or if that's something that's later in conversation.
Because that might not be comfortable.
That's right. That's right.
Okay. So she's the administrator. She kind of coordinates all the paperwork, all the documents, all the legal things to make sure everything is put in place. And that's part of the reason that hospice needs to be called in prior to 24 hours before the person passes
Yes.
away
Yes.
to make sure all those things are in place.
Yeah,
And the person is cognitive enough to do those, correct?
correct.
I see it pretty vividly being the chaplain of similar to pain management that a nurse would do for a patient. The social work kind of provides that peace and security when all the legal documents and everything is in place early on in a patient's disease process. Spiritually, it really allows me to speak into their lives and see where they are. And if you can kind of picture it in your mind, if you're in pain, it's really hard to have a peaceful conversation with someone if they're distracted by pain. And it's
True.
similar when that thought is in the back of their mind, well, I don't know who my power of attorney is, or there's a tension that is present when those things are not taken care of, that the social work can then kind of alleviate. And it just provides a real peace and security in the family that the pain is managed, the business end is taken care of, and now we can focus on the
Now we can
quality of
relax.
life. Right, we can relax, we can enjoy the quality of life, knowing that all those pieces are in place.
Fantastic. Now, the other piece of that is the medical piece.
Yes.
Now, if someone goes into hospice, does that mean they no longer get to see their own doctor, or what is that?
No, they can still see their own doctor. What we're going to take the patient for is their hospice diagnosis. In other words, we may have them for dementia, but they may have still heart issues going on. You know, they're still going to see their heart doctor. Hospice does ask of when there is a fall or a patient wants to go to the hospital, call 911. Hospice does want the family to call us first. Our nurse goes out, assesses, and, yes, 911. I mean, we're kind of their 911, they can revoke us and go, to the hospital right away. There's different instances. We're not saying, no, you can't go, but the majority of their patients that are on hospice, they don't want to return to the hospital. They want to be kept comfortable and be in their home. So you can still see your doctor if you still need to go to the hospital. There's still that.
But there is a doctor assigned
Yes,
through
we have
hospice.
There is. Our medical director is Dr. Stephen Foster. He is a nephrologist here in the area. And the nice thing about, again, another hospice benefit, that if we need to have Dr. Foster or his nurse practitioner go to the home, we go and they make physician visits in the home. So it's like the doctor call from,
House calls.
house calls from years ago. And so we have immediate access to our doctor and to the nurse practitioner.
And what kind of things would the hospice doctor do?
Well, for one, he does our face-to-face visits that are every 60 days. That's still looking at that patient, seeing if they still meet the diagnosis. He says yes, they still meet criteria, or no, they don't.
So
Now-
he would have to see them at least every 60 days.
That's right.
And that's a Medicare.
That's now the Medicare benefit, the ruling of January 1, 2012.
Okay.
Now, if we have a situation where a family member's called in, dad's just not breathing, we would really, the nurse can come, but then she may want to call Dr. Foster or the nurse practitioner, and then they'll come out and make a house call for that as well. It's more eyes and ears for that patient.
And they would be the ones that would prescribe the pain medication.
That's right.
Or the comfort care.
That's right. Whatever
kind of
is
things.
needed, or it depends. So we get our direct directions from them when the nurse is in doubt about something or needing to talk to either our director of nurses, or then we go to our medical director.
Okay, and they would be in communication then with the person's primary care to let them
Yes, we
know
do.
what's going
Yes.
on.
Yes.
Because if the person happens to go off hospice, the primary care needs to know what what's been happening.
Right, and what we do in the beginning when they do come admit, we send to the primary doc. I mean, that's a misconception of, oh, only your primary doc can refer to hospice. That is not true. There are several specialty doctors that can refer to hospice, but we take it back to that primary doc to say, now, do you want to follow that patient, or do you want to have our medical director follow? So we have both. We have primaries that want to still be kept in the loop, and then we have some, no, we want to pass to your medical director.
So it just depends on the preference of the
That's
primary
right.
care
and then
physician.
It's documented in how it's done.
Okay. And what about the day-to-day care of the person? I mean, you've got the social worker coming out and visiting, and you have the chaplain coming out and visiting, and the nurse and the doctor, and all these people are coming to see you. What about day-to-day, what goes on? I mean, is that...
Well, one of the things not only with the nursing is the CNA. Are they choosing to have a CNA? Some decline CNA, and then some. That's one of the things they mainly want is the CNA to help with those assist in daily livings, the ADLs, with the shower, with the light housekeeping, with a little food preparation, or sometimes just relationship. So again, that RN is writing that care plan of how many times a week is the CNA. Medicare guidelines are an RN to be there at least once a week.
I was going to ask about what
One time a
Medicare
week.
requires.
One time a week for the RN. Spiritual and social is one time a month, but River City, our spiritual and social is in there more. Our CNA is in there up to 5 times a week, 6 times a week. You know, it just depends on the care plan that is written. Now, when a patient, when they are actively dying, of course those visits are increased. We do have volunteer, and the volunteer is pretty much just relationship, just companionship.
Companion.
Mm-hmm. And then, it seems like we're missing one other discipline. The spiritual, they can decline. They may not, if they don't want the pastor, that's fine. They can decline that. Volunteer, we have different situations that we volunteer in different ways. We have volunteers that's just what they do. All of our volunteers do have to be drug screened and fingerprinted, as our employees as well, all staff.
I was going to ask, hospice. Now, Medicare is not the only thing that pays for hospice. Is that correct? Does Medicaid cover that?
Well, in a facility, when a patient is on Medicaid,
Mm-hmm.
their room and board is paid for by the room and board is paid by Medicaid, and then the hospice benefit is paid by Medicare.
Okay. What if someone is at home on Medicaid? Does it still go to Medicare?
If they have that Medicare benefit, yes.
Okay.
Now, when there is a patient that's under 65 that does not have that Medicare benefit, they may have disability Medicare.
Okay.
And or the Medicaid.
Okay.
So, and that is also a payer source.
Does private insurance pay for it?
Private insurance as well.
What about if someone has VA benefits?
Yes, VA as well. Now, what happens with VA is just the VA has to be notified that they are on hospice, and then the doc signs that order for that.
And what we were talking about earlier was if someone is through the VA healthcare system and they go on hospice, the VA could actually pay for the CNA to come out.
That's right. It's additional care is what it is, for that VA benefit for those patients.
Is the CNA benefit part of Medicare, or is only certain visits certain amount of time?
No, it's part of Medicare. It's that whole package of that daily rate that hospice
Okay,
gets.
okay. But they wouldn't be able to be there, say, 24 hours?
In a straight period?
Yeah.
No.
Okay, that's what I was trying.
No.
It's a certain amount of time, but
Yes.
that's still paid for.
Yes. And, there are 4 levels of care for hospice. There is the routine home care. That's with what we're talking about, the
Mhm.
weekly visits. There is continuous care. That is where 8 hours of straight care, 4 of that or 50% of that being by the RN. There is respite care. Respite care is where families going out of town, they need mom or dad to go to a facility. We pay up to 5 days of that respite care, in a facility. And then, of course, there's the general inpatient care that, again, meet the criteria, but that's when they're, actively dying.
Interesting.
So-
Well, I need to take a
Okay.
break, but I want to continue on this because that's a big subject. People are concerned about, well, who's going to pay for this?
That's right.
So we'll be right back. This is Connie Clark with the Senior Moment.
Yeah.
Yeah, because I always get
Yeah, and see
questions about that.
the hospice house,
Mhm.
Barbados Hospice House. That's a general inpatient, a GIP facility. That again, you're only there a certain amount of time. You're actively dying. I think I don't know if it's a 10 or a 12 day. There is a maximum time of being in the hospice house
Ah.
for that. And of course, that particular one, it's only for HONI patients. And
Okay.
I think it's one of the things that.
So is there a place, an inpatient place that River City goes to? Is it the hospital or?
Well, we are contracted with several of the skilled nursing facilities.
Okay.
That if we needed the GIP,
Okay.
general
Let-
inpatient, we
let's talk
have a
about-
contract rate for that.
All right, let's talk about that then.
Okay.
And we're back. Again, this is Connie Clark with Home Helpers, and you're on the Senior Moment. I'm talking with Donna and Nathan with River City Hospice, and we were talking about how do you pay for hospice? And you were saying that Medicare pays for it, some private insurance companies, there's some VA benefits, and you were talking about the different
Levels of care.
levels of
Mhm.
care.
Yes.
One of the things you had mentioned was inpatient. Is that
Yes.
what?
It's general inpatient.
Okay.
And it's where the patient is declining and actively dying, but yet they want to say their home, they don't want to be in their home because their grandchildren live there. They want to come out of the home and pass somewhere else. So we are contracted with several of the skilled nursing facilities here that have general inpatient care, and that is care around the clock.
So what they would do is then go from their house to the skilled nursing,
Yes.
and it's almost like a hospital,
Yes.
so to speak.
But the facilities, they do have certain rooms geared for just that quietness and just, the time where families can come. Usually the rooms are a little larger so that families can gather. So there's, you've got, that was just a scenario of, but many times our patients that are on hospice, they want to pass at home. But for those that they've got a little bit different situation, they will come out of the home because of that.
Or if there's something happening that they can't do they can't take care of that situation
Right.
in the home.
You'd be surprised how many patients we have that they live alone. They are left alone and they live alone. And so that's why we're in there daily, weekly, to just keep tabs, and the same as with, your company as well, of just that extra help that is there. Or, they're with their spouse, but the spouse is having a tough time taking care of, their needs as well.
And you said there was a limit as to the amount of time they can be in that.
Yes, I'm not quite sure what the guidelines. I think it's 12 days. It may be 14 days, but
But
in
it's
a
not
general-
6 months.
No, it is not. Mm-mm.
So they have the option they can be at home, but if it comes down to the very end and they decide they want, or the medical situation
Yes,
happens that they have to go into a facility, they can go into a
that's
facility.
right. And hospice will follow there.
What kind of, I'm trying to think of the right way to ask this. What kind of problems do you see with hospice? I mean, like remembering back in my situation with my parents, my mother just really didn't want this to happen. And do you see that often, that people are saying, well, no, I don't want you to come in because they're going to get better, or
Yeah, I think that's probably the biggest problem that I see anyway, is just the misconception surrounding the word hospice and what that means. Obviously we don't come in and cause anyone to die. The disease process is going to happen whether we're there or not, and so we're there to provide the most comfort that we can alongside the patient and the family. And in fact, in 2008 there was a study done, national study on hospice care, and they found that hospice patients live longer, generally 29 days longer than non-hospice patients. And a lot of that is, one, because they're in their home and they're more comfortable, and two, they get very very individualized care on hospice. And like we mentioned earlier, there's 3 disciplines that come in and take care of the whole patient and the whole family instead of just treating the medical condition, which is typically how it's done outside of the hospice environment.
And the pain medication, I remember my dad being on increased doses of it. And I think that's probably where she thought they'd done something to him
Sure.
because they pretty much knocked him out, and she just, well, if we hadn't had that, then, But I know that wasn't the case. But the pain management, I'm sure, has a lot to do with it.
It does, yeah. And that's, again, regulated by the physician on those orders that are written of what meds that can be allowed to be given at the time of when they're in pain. Because that's really what it is, pain management and keeping them comfortable because it takes a lot of energy when they're in pain to live, really. I mean, it's hard on them.
And so when you go into hospice, you had brought up cancer. You no longer have the chemotherapy or the radiation treatments when you're under hospice,
That's
correct?
correct.
Because you're not trying to fix it.
You're no longer seeking curative treatment, and you just want palliative measures, comfort measures. Just keep me comfortable, dignity of life, quality, just let me spend time with my family and be at home.
And if you're under hospice, say your lungs start filling up with fluid, would you get antibiotics then? Or would that be a choice?
It would be their choice, yes.
Okay.
Again, what's the hospice diagnosis? On some of it, for instance, probably COPD, that's one of those natural causes.
But if it's something totally different,
Yeah.
it would be, I guess, a choice of the patient and the
That's right.
family.
Yeah, and they tell us, they regulate their care. They tell us this is what, I want to seek as far as treated, or I know I don't.
So just because you're going under hospice doesn't mean if you get an infection on your leg or something like that we're not going to treat you.
That's right.
Right. It always boils down to patient choice, and I think that's the biggest message that we send out as a hospice agency is that it is your choice. You get an active part in your plan of care as a patient, and even down to which hospice agency you choose. That choice is always yours. The Medicare benefit is yours. It's in your basically decision making that you get to choose what agency you use. You get to choose how active you want to be in the plan of care, and it's a benefit to you that no one else can decide for you. We're just there to kind of help you along and try to help you make good decisions.
So just like choosing your own doctor, if you decide that your loved one is going to go on hospice, or your doctor tells you need to go on hospice, you get a choice.
You should get a choice, yes. Say, you're at the hospital and you're about to be discharged from the social worker there. They're to come and present choice to you of the different agencies that are here in town. And we are one of 4 hospice agencies here. So it is their choice to who they would like to use. It's their right and their choice.
That's interesting, because I know a lot of seniors say, well, you tell me.
Right.
And
many times, they don't know, so they'll go with who maybe their physician would recommend. But there are some that they know who they want to go with, and don't feel bad if say, no, I do want to go with this one. I love it when people call in and they say, we'd just like to speak to you guys. We're talking to all the hospice. And
I was just going to talk about that. That's great.
We haven't made a decision yet, but could you have someone come out? And you said, you bet. We'll go out and come and do a courtesy consult, let you know what we're about, and then they make their decision. I mean, those are ones that they're looking at what their options are, and that's good.
That's a great idea, because that's something I hadn't really thought of. I mean, when someone tells you need to go on hospice, or your loved one, once the shock wears off, if you weren't ready for that, just like anything else, you really do need to do your homework.
Right.
And you all will come out and sit and talk to them. I mean, it's just like having an interview.
That's right, yeah.
Come out and find out exactly what's going on, who's going to be coming out here, how do I get a hold of you, how easy are you located near me, those kinds of questions.
Right.
Definitely. And sometimes it even comes down to just personalities. You know, there are some folks that we just really connect with, and it's a really intimate time of life to be in a person's family at that time. And so we really try to do our best of presenting the family atmosphere. You know, it's a family-run business, and so we really do take it seriously. It is a privilege for us to come into your family, and we want to take the best care that we can to make it, as smooth of a transition as possible.
That's a very good point, because it is a very important part of not only the family but the person. And if someone is in there that's not comfortable with the family, or the family's not comfortable with them, the whole experience.
Right, and it's just a matter of a phone call to the office to say, you know what, our case manager, I'd really like to maybe have someone else. It's absolutely their right. So, I mean, I have a staff of 35 people, and so no problem. We change the case manager, we change the CNA. It doesn't happen a lot, but sometimes it happens, and we're perfectly fine with wanting it to work for them. Because we are coming up on 3 years here in the community, and we're getting where we cared for Dad, and now they're calling and asking if we can care for Mom. So I feel like that's a good thing for us, that they're choosing their right again to call us up. And so,
if someone has called in a hospice and started care and finds out they really are not happy with them, can they change midstream?
yes, they can, but one of the things that I really try to do is find out why. Why are they changing? Because sometimes those may be people that they're not going to be happy with any particular hospice, but they just want to change. So I really try to find out why, because otherwise I want to work with the other hospice here in the area. So it's just, I ask a lot of questions when I have someone to call in and say, okay, I don't want so-and-so, I want you guys. Okay, why don't you want them? So that we can try to smooth that way, because I do want to work with all the hospices here in the area.
So it is possible, though.
It is possible, yes it is.
They shouldn't feel that they've called this particular hospice in and they're stuck with them, so to
Right.
speak.
Right,
Right. It maintains that option of choice.
yes.
That option of choice is always in place. And like Donna said, it's not something that we would promote by any means of changing
But at least
hospices.
knowing that it's there.
But it is an option. It is on the table, and we've been able to build relationships with the hospices in the area, the different nursing facilities in the area, to where our goal is to just provide the best care that we can to the community through our agency. And if that means that we take on patients that maybe didn't fit with other hospices, then that's fine. And also to maintain that patient choice, if there's some reason, an issue that we can't resolve, we have hospices that we would transfer with too. We want to build that relationship to the community.
Okay. And we had mentioned earlier, someone gets better and they no longer need hospice. Then what happens?
Well, they're discharged. In other words, their end of their CERT period comes up. We had a patient just this last week that he no longer met the criteria for the hospice diagnosis that was diagnosed to him. Our case manager, came to the director and said, I don't think, he no longer meets criteria. Our doctor looks at it and agreed. So he was promoted, I guess in a way, and he's, not saying he can't come back, but for now he does not meet the criteria.
So he
because
just
did get better.
goes back to like he was before, like none of that ever happened. He goes back to his primary care physician
Yes.
and continues on.
Yes, and sometimes then that's where home health, steps in. Now, here's the difference with home health and hospice. A home health patient has to be homebound. A hospice patient does not have to be homebound. They can get out, they can go to church, they can go to the beauty shop. So that's one of the differences.
So they don't have to be bedridden.
They do not have to be bedridden.
Okay.
And that's a misconception sometimes of that. Now, like for instance, some of our dementia patients, they do get out for outings. They do get out of the home, for brief periods of time. But you are not homebound. Home health, you do need to be homebound.
So you don't have to be homebound to qualify for hospice,
That is correct.
because people may think that just because you're
Yes.
out
Right.
driving around or something doesn't mean you wouldn't qualify.
For some diagnosis.
Yeah,
we
yeah.
don't have a lot of
But I
hospice
mean,
patients
you know.
that drive, but we do have a few. But we try not to,
And they can go off hospice and then go for however period of time until something changes and go right back on it?
Yes, they can, as long as you have the physician's
Right,
referral.
right. Is there a limit of how many times? Just out of curiosity.
No, the way it works is with your hospice benefit, you have two 90-day periods, and after those have been used, it's 60 days thereafter. And those 60 days, each time requires that face-to-face visit by the medical director, by a physician.
Now, the physician seeing them every 60 days face to face, is that the only piece of the new Medicare sweep that went through that changed for hospice?
At this time,
Okay.
yes, I think
That's the most significant,
Yes.
definitely, in the day-to-day, how we run, how it works. And, it kind of serves a couple purposes. One is that the doctor obviously gets a much more accurate diagnosis of the end-of-life prognosis. But it also builds that relationship with the patient and the doctor, which is very helpful in this time, too.
Okay, and you had mentioned the difference between home health and hospice. Can home health be called in while someone is on hospice?
It can be, in other words, there can be the patient has a wound. We have them for a different diagnosis. Home health can come in and take care of that wound. There has to be clear guidelines on who is doing what. So yes, we do have had where they're on home health for a wound care or something like that, and then we have a different hospice diagnosis.
Okay, so you can have multiple services coming in at the same time for different reasons.
Well, I don't know about multiple.
Well, like home health
with,
and
with
hospice
the
and-
therapies, like physical therapy, speech therapy. With physical therapy, we do a physical therapy consult, and then the therapist is teaching the family and our aide those range of motions and things like that we need the patient to be doing, or the family has asked, because of that improvement for them. So anyway, sometimes there are those therapies.
Okay, so just because you're on hospice doesn't mean you can't have anything else.
That is correct.
Okay.
I mean, it's a case by case. It has to be looked at case by case on what would meet the criteria for them, again, based on their hospice diagnosis.
Okay, very interesting. Every time I sit and talk to people in here, I learn so much, and I wasn't aware of the face-to-face that's now required.
Yes.
I've just always pictured, okay, you're on hospice and you have a hospice doctor and the nurse conveys to them what's going on, and that's pretty much it. But they actually make house visits.
They do, and it's all about accountability now. I think as Medicare is all tightening their belt, that is one of the things that it does prevent from fraud or someone not being really eligible for a hospice benefit. So it just sharpens everyone.
And you said fraud. Hospices have to be certified and inspected and all of that. What
Yes.
kinds of things have to
Yes.
go on?
Well, we are Joint Commission accredited, so we had to go through survey. We opened our doors in September of '09.
I mean, people come in and inspect your records and how you do things?
Yes, our policies and procedures, how we do things. Are we doing what our policies are saying? And then going out and visiting with our patients. And it's a marker for us of better care. We're held to a higher standard. There are different accreditations, but we are Joint Commission accredited, or what we call JCO accredited.
Okay, and how often do they come out and do that?
Well, ours is really due at any time. From now till March, actually, they could, walk through our doors. We don't know exactly when they're going to be here.
So that they don't say, in a month I'm coming, get everything in order?
Yeah, no, we're in order now, because you don't know when they could walk through the door. You could have a complaint filed against you. State walks through your door. You don't know. So we've been pretty fortunate.
And you said you've been here for 3 years.
3 years,
Is
September.
Is this your only location?
Moscow location, and then we're in the process of opening a Sandpoint location. And
Oh, interesting.
Yeah, and then we have patients out in the Silver Valley as well. So right now, the counties that we're serving are, help me, Nathan.
Kootenai.
Kootenai,
We
yes,
got that
yes.
one.
Kootenai, Bonner, Shoshone, Benoit. Primarily, those are the
Yeah, those
four
are
that
primary
we
locations,
really
yeah.
serve right now.
And so you're primarily Idaho. Can you serve somebody in
No,
Washington?
No,
Okay.
we're just Idaho.
So if agencies served both, they would have to be surveyed by both states, correct?
That is correct, yeah.
Okay.
Yeah, and Washington is a certificate of need state, so I believe right now in Spokane area there are 3 hospice there, maybe 4. But no, we're just in Idaho, and then my sister's company, I'm from Texas, but I've been up here 34 years. If you go on our website, you will see that I think there's 15 hospice agencies, River City Hospice, in the state of Texas. So they're just kind of scattered throughout Texas.
So it's Texas and Idaho.
It is.
Okay.
Yes. Mhm.
When do you foresee your Sandpoint office opening? Hopefully.
Soon, in the next 6 weeks.
And you'll have the full complement of people up there as well.
Yes, yes. As a matter of fact, our nurse is already there, and that's what's so nice. We already have her in place. She's been with us over a year now, and she is from that area and lives in that area.
Do you have people physically in Benoit and Shoshone, or do they come from here to visit there?
Right now they come from here, but we are in the process of interviewing for staff on that side of the pass.
So that you would have a staff there, so if someone needed someone immediately,
Yeah.
they would be able to get there.
What we like is our response time is 1 hour or less to get to that patient. So
Fantastic, fantastic. Because when you need somebody, you need somebody.
that's right. That's right. So we look at the response times of how long does it take to get there? I know there was a situation this winter when we had a patient in the Silver Valley that we couldn't get to because the pass was closed. And so fortunately they were in a facility and the facility was able to help. But that's been our one instance in our 3 years. So I believe it's important to have the staff on that side of the pass.
Oh, absolutely.
So we're looking into that.
Absolutely.
But yeah, we're growing, we're expanding, and as our census grows, we bring on more staff.
Well, that's fantastic. If someone wanted to get in touch with you, how would they do that?
Well, we do have a website. It's www.rivercityhospice.com. Our local phone number 777-2489, and we're at 3726 East Mullen in Post Falls.
So you're right down the street from Walmart.
We are right on the corner of Regal and Mullen.
So, and I think the Department of Labor is just
they're
behind
back
you
behind
all.
us.
Yeah.
Yes. Yeah, but we're right on Mullen.
So if someone wanted information, they could either call or stop by your office.
That's right. Yes, they sure can, and we can meet some of the staff and ask any questions, and maybe this interview will create some questions, and we're there to help.
Well, we always run into situations when we're caring for people, relating to hospice and what they do and what they don't do and that sort of thing. And so it's really good to have someone you can call and say, hey, I have a question. This is a situation or whatever. And you guys are right there to answer them, which I think is fantastic.
Right.
And you're right here in Post Falls.
Yes, we are.
And you're going to have one in Sandpoint, which I think is fantastic, because that way Sandpoint will have a choice.
Yes, they will, and that's what's been nice. The hospice that is there, I feel like we already have a good working relationship with them, because they will call and say, we have this patient, we can't take another patient, could you guys help with this? And that's a good working relationship, because it's about the patient.
Oh, absolutely.
And getting the care.
Absolutely.
So we're excited to be there.
That's fantastic.
Yeah.
I am really, really happy for you.
Yeah, thank you.
And again, if anybody has any questions, please give River City a call. Interview them,
Yeah,
to
exactly.
see what you think, because it is important what agency you call and that you feel comfortable with them, and you do have a choice.
Do.
And
One of the things I might mention too, as far as misconceptions about different words, we are always in need and greatly welcome volunteers. And, part of the word hospice volunteer, most people picture, sitting by bedsides and things like that. And that's one thing that we would like to kind of educate people about. So if they have questions about that too, of what does it mean to be a hospice volunteer, it covers a broad range of duties and opportunities to serve people here.
And it doesn't have to be 8 hours a day, 5 days a week.
That's right. We
No,
work with your
they're
schedule.
short assignments, yeah.
Mhm.
They're short.
And it's very rewarding to be able to comfort somebody, during that time. Well, I appreciate both
Yeah.
of you coming in
Well,
here.
thank you, Connie. It's a privilege to be here.
Thank you so much. And again, you've been listening to the Senior Moment with Connie Clark with Home Helpers and Donna and Nathan from River City Hospice. Thank you.
Thank you.
You all have a wonderful weekend.